Okay, I don't know why y'all are moving.
I don't either.
Okay, so Julie and Taylor have moved to the bags. That's probably the bad sign. I don't know why y'all do that. Why do you do that?
I don't know, it got kind of tired to like look like that all the time, so it's kind of nice looking straight out.
Yeah, but I'm short. There is no, I
The screens on you kind of
mean,
like.
Jordan's taller than I am at the second level, so. I'm just
Also,
messing.
isn't it a little bit weird to sit in the same spot without any assigned seats, you know? Like, we have the flexibility.
It's very comforting to me when I know where you are.
You know?
She's like that.
So we have have you, or is this your first hour with us, or were you in the last?
I was in the last one.
Okay, so have you been introduced to the group?
I have not.
Okay, please, or Boomy, is she with you today?
Yes.
Okay.
This is Mesa.
Okay.
She's a recent OU graduate.
Oh, you grad, okay. What was your degree in?
Psychology.
Psychology. Okay, that would be very helpful in this group, in this program. Okay. So you're interested in applying to the VF, and I'm not laughing at you, I'm laughing at us. So you, so just graduated? Interested in applying then for the next upcoming class?
Yes, I already applied. I
Okay.
just turned in my application.
Okay, great. So hopefully we'll see you in this next month in interviewing.
Yeah.
Okay, well, we're glad you're with us today. Okay, since we're entering flu season, I brought sanitizer because I'm addicted to this stuff. It dries your skin out. I know it's terrible. I know it's not that effective, but I just love it. So anyway, hopefully it won't walk out. And they don't always fill them up around here, so.
I just think I would to say thank you from the class for cleaning the classroom.
Oh, yeah. Well, you know, they divert the help. All the camps and the dorms all suck the life out of here. So I haven't had my trash dumped probably in the last week once by someone who is, not their fault. It's how the campus distributes people, so. Anyway, I love the smell of cleaning products. I'm not very clean person. I'm not a very housekeeping person, but you're welcome. Okay. We'll finish up at 10 till 12 today, like we usually do. But if I need more time, then we'll talk about that at the very end. DMARDS is a fairly heavy lecture because the drugs are so. They have so many things that you have to do before you use them and monitoring while you use them. And then understanding just the management of RA and SLE is become much more organized, and so there's lots of things to kind of understand. So it's a big lecture. So today we're going to do gout and osteoarthritis. Have you had gout ClinMed? Okay, we had OA ClinMed. Dr. McNeil. Okay, so that was my suspicion looking at the schedule. So let's look at, I've got two short videos, one on each, that will just help to explain it. So let's look at this. This is our...
Gout is a chronic crystal deposition disease that is the most common inflammatory arthritis. Prevalence of gout is rising. This is potentially due to trends such as increasing age, obesity, and lifestyle factors. In most patients, gout is caused by inefficient renal excretion of uric acid. Decreased excretion of uric acid leads to hyperuricemia, or elevated uric acid levels in the blood, causing urate crystal deposition in the joints, organs, and other connected tissues. Gout and hyperuricemia are independent risk factors for hypertension, CVD, CKD, and diabetes, and have been linked to obesity and osteoarthritis. In humans, uric acid is the natural end product of purine metabolism. The production of uric acid comes from two sources: the degradation of purines during normal cellular metabolism, and the breakdown of dietary purines in the gastrointestinal tract. Most uric acid produced by the body is eliminated by the kidneys, and the remainder is eliminated by the gastrointestinal tract. Within the kidney, the glomerulus filters the blood. The resulting filtrate passes through the proximal tubule, where over 90% of uric acid is reabsorbed back into the blood. Multiple transporters, including URAT1 and OAT4 in the renal tubule system, are involved in uric acid reabsorption. URAT1 is one of the major transporters in the renal proximal tubules and reabsorbs most of the filtered uric acid from the lumen, thus maintaining overall uric acid homeostasis. In humans, uric acid levels are regulated by a balance between uric acid production and elimination. In most patients with gout, hyperuricemia results from inefficient renal excretion that may be due to alterations in transporter function. Alterations in transporter function results in higher serum uric acid levels in gout patients. When uric acid levels rise above the serum solubility limit, monosodium urate crystallizes out of the serum and deposits in joints and soft tissues. These crystals, or microtophi, may not be readily visible without special imaging. These crystals can continue to build up for years. Eventually, and without warning, an immunogenic event occurs, triggering a powerful inflammatory response. The patient experiences an acute flare of gout. Acute gout flares can be caused by many factors, including joint trauma, dehydration, and fluctuations in serum uric acid levels. Acute gout flares can last several days and usually resolve spontaneously. Without urate-lowering therapy, continued deposition of monosodium urate crystals may lead to visible tophus formation. Crystals in and around bony surfaces can perpetuate the inflammatory response and cause permanent bone and joint damage. Management of acute gout includes drugs to suppress inflammation, reduce pain, and hasten recovery time. Following an acute attack, the likelihood of recurrence is high, up to 60% in the first year. Patients that experience frequent recurring flares may require urate-lowering therapy to protect against recurrent episodes and prevent the development of tophi, which can lead to chronic destructive arthritis. Gout is usually treated through a combination of pharmacological or non-pharmacological means, including caloric restriction, reduced alcohol consumption, and dietary modifications. Long-term pharmacological management of progressive or recurrent gout aims to reduce serum uric acid levels to less than 6 milligrams per deciliter, or in some cases to less than 5 milligrams per deciliter. Unless serum uric acid levels are lowered below the saturation point of monosodium urate, crystal deposition may continue. Maintaining low serum uric acid levels prevents crystal formation and deposition and promotes crystal dissolution.
Anyone have experience with gout? Either family members or other ways that you have encountered it?
My mother-in-law has really backed out in her speech.
Okay, anything you want to share about that?
There's nothing specific, it just, she goes through, it's kind of episodic, like inflammatory response. So there's just days where she won't really walk around or get out of the house much because her gout's flaring up. So that's all I really know.
Okay, well, you've described it well. It's very painful and very disabling. So I know I stand up here and tell you a lot, but you will see a lot of gout. Especially if you deal with older folks, that you'll see it in emergency rooms or departments if you work in that venue. You'll see it in primary care because a lot of the drugs that we use, a lot of the diseases that we treat chronically are associated with gout or will precipitate gout. So it's not an uncommon disease for you to come across. Just the way I've organized this, so I put some of the ClinMed stuff up front. We'll cover it just so you can understand the context of the medications. At the end, as I sometimes do, I put the details about the drugs at the end. Okay, so as I go through, I'm just going to talk about how we treat. We'll talk about details of drugs at the end of that section. Okay. So if we start on page 3, so gout is mostly a problem of the fact that we as in our diets, we take in a lot of, all of our foods contain purines. So what are purines? They're what?
Yeah.
So maybe
Nucleotides.
bold.
Nucleotides?
Say what?
Are they nucleotides?
They're part of nucleotides. What are nucleotides? What do they make up?
DNA?
DNA. So they're gonna be in the nucleus of everything you eat, okay? So purines are one of those bases. So a nucleotide has a base, right? Purines are purine and pyrimidines. So you've got guanine, adenosine, what's the other one? Guanine,
That's A and G.
uracil. Okay, so purines are two of those bases. I put them on the next page, I think. So in the liver will metabolize those into an end product that is called uric acid. That uric acid is something that we don't use metabolically, but we have a hard time getting rid of. The kidneys are our main source for getting rid of uric acid. If we can't get rid of it, or we produce too much of it, then we get gout, or where we get uric acid levels that are elevated. So high uric acid levels in the blood are referred to as hyperuricemia. You can have hyperuricemia and never get gout. So hyperuricemia is not gout. The higher that level of uric acid is in the blood, the more likely it is to precipitate out. So it has a solubility factor that is very close to the pH of the blood. So once you get about 7 milligrams per deciliter concentration in the blood, then you'll supersaturate the liquid and the uric acid will precipitate out. Now it doesn't usually precipitate out in the blood, it precipitates out in joints. So the uric acid will move into the synovial fluid, and because the synovial fluid usually is a cooler temperature, and the pH it may be a little bit more acidic, then the uric acid will precipitate out. So I put in your handout that your big toe is one of your major joints that will be affected. It's the furthest away from the core. So your fingers, and your toes, ankle, knees can be affected, but the joints that are further away from the core of the body are the ones that are most likely affected. Okay. So when the uric acid gets into that synovial fluid, it will precipitate out and it will crystallize like they showed you in that picture or in the film. When it precipitates out and those crystals form, then the body perceives it as foreign and will mount an inflammatory response against it. So the neutrophils that are in that area will phagocytize the crystals and release cytokines or chemokines that will attract more macrophages and neutrophils into that area. So that's what sets up in the inflammatory response. So that's what an acute attack is due to. If you do nothing, the attack will resolve. But it will probably continue to come back if there's nothing that removes the offending agent, which is the uric acid, in that continued production. So you can set up a chronic inflammatory response. And the body will do all kinds of actions against that uric acid buildup and produce what we call tophi. And tophi are, there's pictures on that first page. In the ear, if you look at the next page, page 4, that woman has tophi that you can visibly see. And you can see the inflammatory swelling in that x-ray. I've got other pictures as we go through. So those tophi can become very large and they can become multiple. They can affect multiple joints throughout the body. And they can set up what we call then a gouty arthritis. So the acute gout attacks are, like Lindsay has described, are disabling. They're very painful. Patients will seek help usually because of the pain. So that's one problem. The complications of that chronic inflammation leads to those tophi, which then lead to destruction of joints. Those tophi And the other problem that can occur is the formation of uric acid stones. So the long-term complications of untreated gout are the joints, on the joints itself, and the other on the kidney. So you can get what they call a gouty nephropathy. And we really want to avoid that because it decreases their renal function and their ability of their kidneys to work well. So that's kind of the short and skinny of the pathogenesis of gout. So our treatment is going to be geared towards one is anti-inflammatory. The second is then decreasing the production or enhancing the elimination of uric acid out of the body. Okay. So that kind of gives you a background. Let's see. I am not going to test you on the ClinMed part or on the PathoPhys. Most of what I've said is on that first page. Oh, let me point out something on page 3. Under those chronic manifestations, I talked about arthropathies and gouty nephropathies. The other thing, I've mentioned this in the past, but haven't made a big deal out of it. Remember when I talked to you about diseases that kind of occur together that we sometimes look at separate but really have a big core? So those are diabetes, lipid disorders, cardiovascular disease, what am I forgetting? Hypertension, thank you. And I told you that they really are they're just peaks of the same iceberg underneath. And what did I tell you that is in that iceberg is usually the factor that weaves them all together is what? We talked about insulin resistance being part of the commonality of all of those. Another one you can add to this is uric acid. So uric acid commonly high uric acid that can lead to gout will also be in this picture. So you will commonly see it with these folks. So treating those comorbidities will often help you with treating the gout as well. That hasn't been so much emphasized in the past, but it is now more being recognized as part of a cluster of problems. On that page 4, bottom of page 4, whoops. The disease cycle, this is fairly common. This is a really good descriptor. Where you have an asymptomatic hyperuricemia. You can see people with uric acids of 10 that will have no gout, but their likelihood of getting it is very high. So they'll be asymptomatic and then they will have an acute flare. That's what that number 2 is. Once the flare is over, whether you treat it or not, they will go into a period of time where nothing happens. And then they'll have another flare. Sometimes people will only have one gout attack and never have another one. So that can happen, particularly if you've removed the offending agent. Let's say they're on a drug or their diet changed or they stopped drinking as much alcohol. They lost weight. Something happened that changed that dynamic. They may not have another one again. But the likelihood is a majority of people will have another flare. And the longer the disease goes, the shorter the time is between flares. So they may go months, they may go a year or so, and then as the disease goes on, they may only go a few weeks or a few months or a few days, depending on what is going on with them. If that cycle goes on long enough, then you will start to see those chronic complications come in, the gouty arthritides and the nephropathy. Okay. Most of those. So in terms of, go to the bottom of page 5, with overproduction it can be several different things. One is it can be due to a genetic problem. That is a very unusual. They just make too much purine. The second is excessive dietary purines. So in the past, gout was known as a rich man's disease. If you look back at pictures of like Henry VIII during the 1600s and so, you will see the disease referred to as that, because those people could afford the foods that then led to that. So it's usually meats, it's organ meats, so sweetbreads, kidneys, liver, bacon, things that are heavy in fat. Those tend to be the foods that would then lead to the gout. If you're pretty much a vegetarian, even though you'll take in purines, the purine load is lower. So it's unlikely that they would get it from a dietary source. The other would be cancers. So cancers can cause great turnover in cells, and so you will see, especially if you're dealing with a solid tumor that you're reducing with chemo, you will have a lot of release of cells that are then destroyed, and those people tend to have very high uric acids. And so those are treated as a result of usually of a treatment process. Okay, so that's overproduction. Not the most common problem. The more common is being able to get rid of it. So uric acid undergoes a really odd elimination. So it's all filtered by the glomerulus. And then most of it's reabsorbed. They showed you in that video about those two enzyme systems in the proximal tubules, or transport systems rather. They reabsorb. And then we re-secrete it into the urine again. And then we reabsorb it again, so that we reabsorb about 90% of it, and we excrete about 10%. Odd. One thing that you should put together is that drugs that undergo secretion will tend to have big interactions with or cause gout. Or if the drugs that we use will tend to have a lot of interactions and precipitate gout because of their effects on the renal handling of uric acid. This is where the majority of problems occur. However, we don't focus most of our attention on this part of treating this part of the problem. We tend to put our treatment towards decreasing the production of uric acid. Okay, we'll leave it there. Secondary causes are listed there. You'll see several of the ones we've already talked about. Moving on to the bottom of page 6, in terms of definitions, we're going to look at hyperuricemia, gout, and tophi. So hyperuricemia, again, is not gout, but it does give you, you can't have it and get gout. So it has to be present. So usually it is when your levels are starting to climb above 6 to 7. You'll see it defined different ways. And the higher that goes, the higher the risk of gout goes. When I worked for an endocrinologist, he had us treat everybody who had uric acids of 10 and above because the risk was so high. But in between 7 and 10, it's hard to predict exactly who will get gout because of that. Okay, so next page, gout is defined as an arthritic condition resulting from the deposition of those crystals in joints, bones, or soft tissues. So it can occur in organs, you just won't see it very often. It's mostly going to be in joints. And then tophus, which is one, and tophi plural, is the deposition of those uric acids on the surface of skin or cartilage, and is a common problem in gout. Crystallization and inflammation, I think I've talked about all of that. Talking about the chronic inflammatory response, let's go down and just hit some points under the tophus. So those tophi, again, are seen as foreign. So the body will mount, again, a chronic inflammatory response to them. And it's a granulomatous inflammation. It's a very complex system. It's well organized. It will it will attack the bone, so it affects osteoclasts and osteoblasts. So the osteoclasts lead to the bone erosion, and you can see that on the x-rays of people with advanced gout. You will see those bony erosions. The osteoblasts are more destroyed by the process, as instead of being actually brought into the process, they're more killed off or phagocytized by the process that's going on to attack the uric acid. Okay, so I think that's my ClinMed spiel. Does that give you a picture of what we are dealing with? Anybody have questions about that? Yes.
So if we don't really use the uric acid much, and only 10% leaves, does the rest just go out to the GI, or what happens?
It can be eliminated GI. Most of it's just recirculated, re-excreted throughout the day. In between meals, then you're getting rid of more of it. So the longer you fast or so, then that level's going to go down. Of all the things you're going to treat, this is one of the easier ones. It really is. You don't have a lot of drugs. It's fairly straightforward. It's more making sure you don't make somebody worse with the drugs you use. And you've been introduced to most of the ones that we're going to use. So overall, you would promote health. So you want them to eat a healthy diet. You want to get them to eliminate, if they are really concentrating their diet in areas that are high in purines, getting them to go to a more balanced diet would help. So lower fat dairy products, lower fat leaner meats. I'm not sure why that would make so much a difference, but you can see most of these are your higher fat meats. Also, there is good evidence that the high fructose containing products also aggravate gout. So limiting those, encouraging vegetables. Avoiding alcohol overuse. It will be not uncommon for you to see the first time a person comes in will be after a period of heavier drinking. Could be just much above what they usually do. On the weekend, went to a party, then they'll show up in your ER in a couple of days. So getting their alcohol use down will help. Okay, next page, page 9. Most patients will present early because of the pain. Once it starts, it intensifies fairly quickly over a period of a few hours. The sooner you recognize what it is and the faster you treat, the sooner you treat, the shorter the attack will be. The longer it goes on, the longer it takes for you to get resolution of the symptoms. It's probably because you just allow more of those inflammatory cells to get there, and it's just harder because you're dealing with, now they're in a kind of a closed off compartment of that synovium. Let's see. This is one of those times where we use full dose of things. Full dose, we'll use steroids, we'll use non-steroidals, or we'll use a drug called colchicine to stop the inflammatory attack. Using ice is often helpful to the patient. Again, most attacks will resolve in a short period of time, 3 to 7 days. I've never seen one in 3 days, but in a week, it can certainly resolve on its own. If it's mild, patient may not notice it, may not come in for treatment. But most of the time, you're going to see more moderate to severe, and they will show up. Resting the joint, icing the joint. It'll take a few days before they can walk around on that without pain. So let's see, down at the bottom, gout is managed in 3 stages. The acute attack, that's the one we've been talking about the most. One is then prophylaxing them, so putting them on something that will prevent. And the third is, if they do have tophi, is treating them long enough to allow those tophi to dissolve. So you can get them to dissolve. We have some very powerful drugs now that we can use in people who have multiple tophi, but that can also take months. So it can take a good 6 to 12 months to resolve all those tophi with intentional treatment. Okay, So page 10. So the goal of therapy of an acute attack is prompt and safe termination of the pain and disability. Most of the time, early in the disease, it will be one joint. It can be multiple joints, but often it will be one joint to start with. Usually, again, it's going to be big toes, might be the hands. I've never seen the hands present first, but that could be just what I've seen. But toes, ankles, knees, very common. We've talked about treat fast to resolve quickly. Most of the times people will have another attack, but we don't always start prophylaxis right away. So we usually wait until people have had at least a couple of attacks in like a year's period of time before we will put them on prophylaxis. So we usually treat them, educate them about what to do to get their risks down, treat their other comorbid diseases, make sure their blood pressure's been treated, their diabetes is in as good a control as they can get. So it's focused on lifestyle, health, and reducing those risks that put them, that increase their uric acid. It may be taking them off medication. Diuretics, very common cause. Starting somebody on a diuretic is a common precipitant. Niacin is a common precipitant. It raises uric acid levels. So people can get that over the counter. So if they've decided to treat themselves, their cholesterol, or to just take high vitamin B intake, they may end up, that may end up precipitating an attack. So which drug to use? If you look at under the anti-inflammatory medications for gout in that second section, you'll see the things we commonly talk about. So what is the renal function? That will come to bear on what drug we will choose. Their cardiovascular state can certainly move us away from maybe a non-steroidal. GI disease, because some of these drugs are very hard on the GI tract, like colchicine. If they're allergies, of course, or poorly controlled diabetes. So the drugs we use for an acute gout attack are glucocorticoids, non-steroidals, or colchicine. There are preferences for what people do, but you would not be wrong in any of these as long as there is not a contraindication to the use of the drug. With the glucocorticoids, we can inject their joint. If they only have one joint or two joints and they're small, then you might want to just inject those. We can use oral steroids. They will help, they'll pretty much take out anybody's gout. Non-steroidals have been the kind of the center and the most common go-to over the years, but given the facts, or given the problems with non-steroidals, people have moved away from that. So I'd say there's been a shift to use steroids more, non-steroidals less. But if you've got people who are having frequent flares, you can't use steroids all the time. It's too big of a steroid burden. So that's where, when do you institute prophylactic therapy or preventative therapy, and which drug you choose may be determined by when was their last attack and how was it treated. Okay, page 11. So intra-articular, if somebody can't take oral, of course you could use an intra-articular. You could use an IV. If you have somebody in the hospital who's having a gout attack, you could use IV glucocorticoids. So I say it's a very unusual route of administration unless you've got somebody hospitalized. IM is probably your last resort of glucocorticoids. It's not preferred in any situation, but it may be something that you don't have a choice in, but it would be after everything else has been ruled out. So again, if you've got small joints or limited number and you are good at it and you know that it is gout, so unless you've got confirmation, you really shouldn't be sticking steroids into a joint. So you know it's not an infectious process, you know you don't have a septic joint, so that would be more, it may be more common in people who already have a known diagnosis. So the first time you would, you're usually going to try to aspirate that joint and pull off fluid and look at it so you can have a definitive diagnosis. You can't do it, you can't make a definitive diagnosis of gout unless you look at it under a microscope and you see the crystals. That's pathognomonic. So if I say something is pathognomonic for a disease, what do I mean?
You-
Below my hearing level. What's pathognomonic?
Like if you see it, then it's probably that disease.
Pathognomonic means it's only that, yes. So if you, I'm trying to think what else is pathognomonic. So it can only be one thing, or we only know of one thing that causes it. So uric acid crystals in a fluid, it's gout. Okay. All right. The drug of choice is triamcinolone. That's the one we use in intra-articular. Very rare that we would use another steroid. The amount that you will inject will depend on the size of the joint. So little joints, 10 milligrams, large joints like the knee would be 40, so somewhere in that range. You also have to think about the amount that you are going to give because it will get absorbed. Not all of it, but a lot of it will. So if you have a poorly controlled diabetic, their blood sugars will go up. What I have seen in practice is in patients who are fairly well-controlled diabetes, their blood sugars will go to 4 and 500s or so the day, about 24 hours after you give that dose. And the blood sugars will fall off over a period of about 5 days. But it will certainly cause the patient concern if they're checking their blood sugars. You'll be getting phone calls. Let's see, oral. The thing with oral is that we start them on a pretty good dose. I've got it there, 30 or 40 milligrams. It's kind of a moderate dose. Once or twice a day, splitting it usually if you're the higher the dose you're giving. The thing with steroids is that they're very effective, but as you pull them off, as you taper them down, you can get rebound flares. So usually we will treat them, even with the non-steroidals, we'll treat them at full dose until their symptoms resolve, and then we will start the taper. Usually tapers here, I've got, I think, up to 10 days. You may have to taper over 14, 21 days. Same with the non-steroidals. We'll see that once you've treated them and their symptoms have resolved, you still are going to taper them off. Just because that inflammatory response can still be smoldering, you haven't killed it out, but at least the symptomatology's gone away. So usually we're going to taper off any of the drugs that we use. So non-steroidals. The sooner you start them, the more effective they are. So we really like to get them in the first 48 hours, sooner if possible. All the things we've talked about before are also pertinent here with regards to the contraindications to non-steroidals. They're listed there at the bottom. So renal insufficiency, uncompensated heart failure, if they've got uncontrolled hypertension, their kidney function, if they're on anticoagulants, those who've got peptic ulcer disease or a history of gastritis, and then your elderly. So all those things have kind of led people to move to the glucocorticoids. Use full dose, I've given those to you on the back. You can use any of the non-steroidals. Usually we use the non-selective. They usually tend to be better. Celebrex, if you use it, a COX-2 selective, you tend to have to use higher doses. So most people will go with the non-selective and they're cheaper. Usually are going to treat them until you've got a couple of days of no symptoms and then start tapering them down over a couple of weeks. Questions about those? So those are two drugs you know. So let's talk about colchicine. I don't think we've encountered it before. It is such an interesting drug. I love it. But it's very difficult for people to tolerate. It has a narrow therapeutic window. So that means what? Therapeutic level, toxicity level are very close together. In fact, in this case, they overlap. So it has a very narrow range. In fact, when I was sitting in your shoes, the way we would use colchicine is we would just give it to them until they threw up or they had diarrhea so bad they couldn't stand it. We just treated them to toxicity and then backed off. We don't do that anymore. We have a different method and we found it to be as effective, and that was one of the ways we used to do. We'd like to get this drug started within 24 hours. This drug, and I'll go into more detail in the back of the handout, this drug is fascinating because what it does is it impairs the ability of white blood cells to move. So it interrupts their ability to make the microtubules that form the skeleton that allow them to form those pseudopods and flow. So the ability of them to migrate. So most of the time what they're going to do is they're going to impede the peripheral white blood cells from moving to that joint. Whatever's already in the joint probably can't do anything about. But those that have been being recruited can't move. Okay. So they are microtubule poisons. And that's how their effect, or that's their anti-inflammatory effect, different from what we've seen in others. It's usually used as a second tier. So usually people will use a glucocorticoid or a non-steroidal, but if you can't use those, you can consider using colchicine. Severe kidney disease, it can be used at lower levels of renal function than non-steroidals can. So it makes it a little bit helpful. Same with liver disease. You can use it in people who have moderate to even severe liver disease in reduced doses or giving the doses further apart. So contraindications to colchicine down in the middle of that section. So this will get confusing. We'll just walk through it and then we'll take a break. Let me go down to first about, let me skip the contraindications, go down, and I'll weave that in as we talk about this. So if someone comes in with an acute attack and you want to use colchicine, you have to ask the question, have you been on colchicine? Some people will take it prophylactically. They'll be on it once or twice a day to prevent an attack. And in those low doses, most people can tolerate it well. You might use it in people who have contraindications to the other drugs that we often use for prevention. If they haven't been on colchicine in the last couple of weeks, then you give them 1.2 milligrams as a first dose, and in 1 hour you give them half of that, 0.6. So the total dose for an acute flare is 1.8 milligrams. I want you to know that, it's in your objectives. If you're going to put them on colchicine as a preventative, then you can start that within 12 hours. That's the easiest. If they have had an acute flare and been treated with colchicine in the last few days, then you would want to reduce the dose. Or you may want to choose a different product altogether because it takes a while to get rid of that, rid of the drug. So if they're on, let's go to that second part. Yes, they're on prophylactic. They're taking it daily. Then choose another, we're going to choose something else. Or if they've been given the drug acutely in the last 2 weeks, then we're going to use something else. So the more colchicine they have received in the recent past, in the last 2 weeks, is usually going to drive us to a different drug, okay? If they have severe liver or renal impairment, you may be stuck in terms of what you can use. You could use a glucocorticoid, but non-steroidal you would have to stay away from. And colchicine you would probably stay away from at that point. If you're also, if they're on a strong 3A4 inhibitor, remember those are pretty common, so if they're on that, you would also avoid the colchicine. You can combine for patients who have severe or polyarticular presentation, you can combine drugs. So the colchicine plus the nonsteroidal will work, oral corticosteroid plus colchicine, or intra-articular plus colchicine, or a nonsteroidal. So you can combine. Comments there? Okay, let's take a break. We'll start back at 10 after.